Hello, I'm Dr. Wright, and this video represents a portion of a series on lung pathology. The videos are directed towards medical students and junior pathology residents. However, other healthcare professionals might also find them useful. I've restricted the videos to pathology only, so physiology, mechanisms of diseases, and clinical findings are not going to be discussed. The series actually started with normal lung, so you might want to go back and see these episodes just to give yourself a baseline. I'd appreciate your comments, and if you find these videos useful, I'll expand the series. Thank you for listening. This video is directed towards the pathology of asthma. The learning points are to know the definition of asthma, to learn the gross features in the lung associated with asthma, to learn the microscopic features seen in the airways of a patient with asthma, and to learn the features which can be found in cytologic preparations from a patient with asthma. The definition of asthma is quite complex, as defined by the National Institutes of Health. It is based on etiology and physiology rather than pathology, and you can read the various items here. Asthma classification is also quite diverse. It can be based on severity, or it can be based on the instigating agent. In a patient with status asthmaticus, the lungs can be quite startling. They fill the chest, i.e. they fail to collapse when the pleural surface is open. There can be areas of hyperinflation, areas of atelectasis, mucus plugs, which can be quite startling, and focal bronchiectasis. In this lung of a patient who's died with status asthmaticus, the lung is hyperinflated, and there is a large mucus plug which stops deflation of the lung on its removal. This is seen at a higher magnification here. On these microscopic slides, mucus plugs can extend from the segmental airways, as seen here, down to the respiratory bronchioles, as can be seen here. The membranous bronchioles contain large mucus plugs and show the characteristic abnormalities of asthma that I will discuss later. Mucus plugs can also be identified in a patient who has asthma but who dies from something other than asthma. These Goff sections show the complication of multiple and chronic asthmatic attacks. This is an area of atelectasis, and here is an area of bronchiectasis. The airways of an asthmatic show extensive abnormalities in almost every compartment. In the epithelium, you can see goblet cell metaplasia, squamous metaplasia, cilial damage with cilial sloughing, and epithelial cell sloughing. On this micrograph, almost every epithelial cell here is a goblet cell, and note also the mucus plug present here. In this micrograph, there is goblet cell metaplasia, but there is also squamous metaplasia, and note again the large mucus plug present in the airway lumen. Note also the abnormal basement membrane. The basement membrane in an asthmatic tends to be thickened, but also thickened in an irregular fashion. In this slide, please note also the presence of eosinophils, goblet cell metaplasia, and mucus plugging. The basement membrane is divided into three components. There is a lamina lucida, which is immediately underneath the epithelium, a lamina densa, which is composed of collagen 4, laminins, integrins, and intactins. The lamina reticularis is composed of collagen 3. It is the lamina reticularis which is thickened in a patient with asthma. The wall of the airway in an asthmatic is abnormal. There is subepithelial fibrosis causing narrowing of the airway. There is inflammation in which eosinophils are featured. There is muscular hyperplasia and bronchial gland hyperplasia. This immunoperoxidase stain features a number of eosinophils. On this slide, there is bronchial gland hyperplasia, there is muscle hyperplasia and thickening, there is thickening or expansion of the subepithelial component, there is an abnormal basement membrane, and there is epithelial cell sloughing. So the microscopic features of asthma are mucus plugs in the airways, goblet cell metaplasia of the epithelium, squamous cell metaplasia of the epithelium, a thickened and abnormal basement membrane, epithelial shedding, fibrosis in the subepithelial space, bronchial gland enlargement, muscle wall thickening, and an increase in inflammatory cells, of which eosinophils are featured. How does this translate into cytology? Epithelial sloughing translates into Crayola bodies, and in this cell block you can see rather extensive epithelial sloughing in these large pools of mucin. A Crayola body is difficult to envision, so I've had these two cartoons which might help you understand how they're formed. If one takes a map of the world, the kind that you hang on the wall, and say that it has increased surface tension such that it now collapses to form a globe, that would be a Crayola body. In this cartoon, the small diamonds of green and blue show the epithelial cells, and with increased surface tension after the epithelium is sloughed, it forms this irregular body. These are Crayola bodies seen in a cytologic preparation. Here is the cell ball looking at the outside, and here is the cell ball where the surface tension hasn't completely formed into a ball and there's a small interior hole. In this slide, there is a flat section of epithelium and a Crayola body where the epithelium has formed a three-dimensional structure. Kirschmann spirals are indicative of mucus plugs in the small airways which have been washed out by the bronchial wash. The inflammatory infiltrate shows prominent eosinophils, which can be seen here, and association with charcoal-laden crystals. Charcoal-laden crystals are these little eosinophilic needle-shaped crystals which can be found usually in association with eosinophils. Sometimes they can be found in the eosinophil cytoplasm. The crystals are made of galectin-10, produced by the eosinophils. So the cytologic features of asthma show Crayola bodies, which are indicative of epithelial sloughing, Kirschmann spirals, which are small mucus plugs, and eosinophils and charcoal-laden crystals, which are indicative of the eosinophilic inflammatory infiltrate. Here are your questions. Question number 1. The answer to question number 1. Question number 2. The answer to question number 2. Question number 3. The answer to question number 3. I hope you've enjoyed this series in the pathology of asthma.